Welcome to AETCM, the emergency medicine channel. A 45-year-old male presented to our ER with complaints of fever and yellowish discoloration of the eyes. On our initial 10-second assessment, patient was conscious and oriented. Airway was patent, no pooling of secretions. Coming to breathing, air entry bilaterally equal, respiratory rate of 25 per minute, saturation of 98% in room air. Coming to circulation, BP of 110/70 millimeters of mercury, pulse rate of 80 per minute. Coming to disability, GCS of 15/15, bilateral pupil equally reacting to light. Coming
Pulse
to
is 80.
80.
Bradycardia with jaundice, where will you get? This is normal. Bradycardia with jaundice.
Obstructive jaundice.
Obstructive jaundice. That is the most common differential diagnosis if you have bradycardia with jaundice.
Coming to exposure, temperature of 100.6 degree Fahrenheit, GRBS of 140 milligram per deciliter. Injection paracetamol 1 gram was given at this point of time. Coming to adjuncts of primary survey.
Paracetamol contraindicated in jaundice.
No.
It is not contraindicated but avoidable. If you are not confident about the LFT, then avoid it, but it is not contraindicated.
Coming to adjuncts of primary survey, VBG was taken showing a pH of 7.410, bicarb of 24.8, lactate of 3.0, bilirubin of 6.5, glucose of 140.
Potassium.
Potassium was 3.5.
What is the importance of potassium? Peristalsis. What are the triggers of hepatic encephalopathy?
Hypokalemia.
One of the most common cause for hepatic trigger is hypokalemia. Other triggers?
Constipation.
Infections.
Melena hematomasis.
Melena hematomasis. Dehydration. Okay. So potassium is very important in the case of jaundice.
CBC CRP point of care was taken showing a total count of 8,000 and CRP of 18. Coming to sample history, a 45-year-old male presented to a ER with complaints of fever, vomiting of 6 days duration. Fever was low grade intermittent, no chills or rigor, decreases on medication. Vomiting 3 to 4 episodes, non-projectile, contains food particles. The patient also gives history of yellowish discoloration of the eyes of 2 days duration. He also gives history of food intake from outside 2 weeks back. No history of any drug intake, altered behavior, rashes, melena hematomasis, abdominal discomfort, constipation or altered sleep pattern. No history of any drug allergies. No history of any travel.
Yellowish discoloration, where on you will look?
Some only on the upper palpable, sclera.
Sclera?
Sclera.
Not upper sclera. Sclera. Then?
The hands, the oral mucosa.
Oral cavity, oral mucosa, hands. Okay.
No history of any allergies, no history of any travel reason.
Sclera, what is the problem of looking at the sclera and telling patient is having jaundice?
Persists for a long time.
It persists for a long time. That is the only problem. Somebody had jaundice in the past, maybe 2 weeks, 3 weeks back. It can persist for a longer period. That is the only problem in looking at the sclera. But sclera is classically involved in jaundice. Even MBBS teaching also sclera is the main area to look for jaundice.
No history of any recent travel, no history of any drug intake, no history of any similar illness in the family.
Travel, why you are worried?
One is food intake from outside.
Endemic area, travel of hepatitis. Okay.
Coming to general examination, no pallor, icterus present, no cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, GIT, the patient was exposed from Cepheus sternum to mid-thigh. Abdomen was distended, no dilated veins, no visible peristalsis. All quadrants move equally with respiration. Umbilicus was inverted center in position. All hernial orifices were normal. No
What
scars.
is the ideal position to look for the veins in the abdomen?
Standing position.
Standing position.
Coming to palpation, no local rise of temperature. Tenderness were present in the right hypochondral area. No fluid thrill or shifting dullness were present.
Tenderness indicates what? Right hypochondral area tenderness indicates what?
Underlying
What are the differential diagnoses?
cholestasis.
One is hepatitis, acute hepatitis. The patient can have tenderness. Second thing,
Cholestasis.
cholecystitis, focal tenderness. Then
Liver abscess.
liver abscess. Then
And cholangitis.
cholangitis and all will not produce malignancies. But most important here, patient is having jaundice. Tenderness means mostly it is acute viral hepatitis.
No fluid thrill or shifting dullness. No hepatosplenomegaly. Coming to percussion, liver was percussed in the right midclavicular area, fifth intercostal space. Coming to auscultation, no brewy bowel sounds were present. Rectal examination was not done. Coming to respiratory system, normal vesicular breath sounds, no added.
What may be the rectal examination finding in a jaundice case? Why you are worried about that? Here it is not done, it's okay. Why it is done?
Clay colored stools can indicate.
Rectal examination. Rectal examination, you are looking for any mass or something. No? Here, why you are doing? Hemorrhoids are very, very common in CLD. So that is the only finding you may get. Some bleed can occur. Okay, these are the things you can get from the rectal examination. Here we have not done it.
Coming to CVS, S1, S2 were present, no murmurs. CNS examination, GCSO 15/15, no flapping tremors were present. Pupil bilaterally equaling to right, all four limbs were having a power of 5/5. Based on the history, we were suspecting acute hepatitis and we sent the LFT and the pre-op serology. LFT came out to be ALT and AST in the range of thousands with ALT more than AST.
ALT more than AST.
Thousands.
Thousands.
What are the conditions you get in thousands? SGOT, SGP in thousands. 1000
one
means
is-
1000, 10, 1000, 2000, 3000, like that.
Viral hepatitis itself can
Okay,
cause
viral hepatitis is the most important and common cause.
drug-induced
Drug induced like paracetamol. Okay.
toxins.
Toxins like? What are the common toxins we come across? Rat poison. That's the most common thing. There are so many other. This one. Then
Ischemic hepatitis.
ischemic hepatitis. Mushroom poison also. It comes under poison. That is also very common in our country. Okay.
ALT and AST were in the range of thousands and INR came out to be 0.98. Pre-op serology was sent.
What is the importance of INR in this type of cases?
Acute hepatitis can progress in some cases to fulminant hepatic failure. Where there is derangement of
Hepatic failure means what? What do you mean by hepatic failure?
there is
Acute liver failure means what?
acute liver failure. There is a rapid progression from jaundice to a raised LFT plus hepatic encephalopathy and coagulopathy.
So three important things. One is hepatitis, second one is coagulopathy, third one is encephalopathy. These three things should be there to make a diagnosis of fulminant or acute hepatic failure. Okay. So is this patient in failure or just hepatitis?
Hepatitis.
The patient is only in hepatitis. Okay.
Pre-op serology was sent and it's positive for IgM hepatitis A virus.
And technically, pre-op serology it doesn't cover hepatitis A.
Hepatitis A, it will not
Pre-op
cover.
serology is the test which is done for as a pre-op investigation. It usually looks at HIV, hepatitis B, and C. So here you have to send independently for viral serologies. Yeah. Continue.
And it was positive for hepatitis A virus.
So IgM hepatitis A is for HAV, IgM. Okay.
So we started the patient initially on conservative management, sir. IV fluids to correct dehydration, then hypoglycemia was
What IV fluids are ideal in a patient with hepatitis?
finger lactates.
NS.
If that is not there, next. This is normal saline, finger lactate, plasma light. Next fellow will tell something else. What is that?
Correct.
Dextrose content, it should be always, because you have seen this patient will have continuous vomiting, he will not take any food, his liver is not working, he will go to hypoglycemia. So always this type of patient require continuous support with fluid and dextrose. Okay, if you can dextrose containing saline, that is DNS, that will be the best option. Okay, so try to give that. If there is an electrolyte imbalance like potassium deficiency, then you can go for ringer lactate. Ringer lactate is also not a good choice. Sometimes it can produce problem. Okay, best is normal saline or DNS.
We initially given 10% dextrose. We actually calculated like daily requirement was like 150 gram per day. So 10% dextrose like 10 gram in 100 ml.
Okay.
So 1 pint contain 50 grams. So approximately 3 pint will cover the daily requirements.
Okay. So that much you have to give. Every patient with hepatitis, acute hepatitis, they may not require any major treatment, but they require treatment with water with dextrose. So either normal saline with dextrose or DNS as such you can give.
Then we go with symptomatic management and daily monitoring of INR and LFTs.
Okay. So what are the things you should avoid in a case of hepatitis? There is no much treatment in hepatitis A. Just give supportive therapy, that is more than enough. What are the things you should avoid?
Avoid contact with the
In hospital, what are the things you should avoid? What is that?
NSAIDs and
So paracetamol, NSAID should not be given. Number one. Then
No IM injection.
no IM injection. Most of these cases can have coagulopathy or thrombocytopenia. IM injection should not be tried. Okay, then third one. Avoid sedatives. So these three basic things you should remember. Don't give this type of drugs. Unnecessarily don't give paracetamol. Unnecessarily don't give painkillers. Unnecessarily don't give sleeping tablets or IM injections. All these things should be avoided. Only supportive therapy is enough. Then
hepatoprotective measures are also given.
what are the hepatoprotective measures?
To prevent constipation, lactulose was given. 30 to 60
That
ml.
is hepatic encephalopathy protective measures. Hepatic protective measures are different. Hepatic encephalopathy protective measures are different. What are the hepatoprotective drugs?
N-acetylcysteine.
One is N-acetylcysteine, other one is L-ornithine, L-aspartate. These are the only two things you can give. Acute hepatitis, you can give N-acetylcysteine can be given. Okay.
We started the patient on N-acetylcysteine.
Okay.
150 mg per kg in
Okay.
5% dextrose 200 ml over 60 minutes.
Okay.
Though it is indicated only in paracetamol poisoning and no recommendation as per.
As such, in hepatitis A, there is no treatment required. They'll have a very high SGOT, SGPT level, and it can come back to normal within one or two weeks. Okay.
And we go with anti-hepatic encephalopathy measures.
Hepatic encephalopathy measures are very important when he is admitted in hospital. What all measures you give?
Initially, mainstream of treatment was lactulose.
Lactose. What will be the problem in this patient? This patient already have diarrhea, because most of the hepatitis A patients will have diarrhea. So lactose may not be required in this type of patient. What other drug you can give?
We can give rifaximin.
Rifaximin, what is the dose?
400 mg TID can be.
Is it absorbable?
Minimal absorption.
There is no absorption. It's a non-absorbable gut sterilizer. So you can give this one. Okay. Should we give, suppose the PTNR elevates, INR elevates to 1.5. This patient's it was elevated to up to 1.7. Should we give anything?
Only if there is bleeding manifestations.
You want to give vitamin K. Is vitamin K indicated in hepatitis? Theoretically, it is not indicated. It is not required at all. Where will you use vitamin K? What is the type of jaundice vitamin K is useful? What is the type of jaundice where vitamin K is useful? Obstructive jaundice. Why it is required? Obstructive jaundice, fat soluble vitamins will not be absorbed. So you have to give vitamin K. Is why hepatitis A produces obstructive jaundice?
No.
It produces obstructive phase of hepatocellular jaundice. How do you diagnose that? Obstructive phase. Alkaline phosphatase will be
Phosphatase,
elevated more than 3 times. But that is only transient phenomenon. Yeah, within 2-3 days it will come back to normal. Alkaline phosphatase come back to normal. So if at all patient develops a obstructive jaundice, you can give vitamin K. Here also you can give. It is not contraindicated, but it is not really indicated. Okay, vitamin K may not be required at all. Okay. Will you give FFP or not? That is a question. In any acute hepatitis, will you give fresh frozen plasma or not? From emergency medicine side, we should never give. What is the problem of giving a fresh frozen plasma? What are the indicators for liver transplant?
INR more than 6.5.
So if anybody who is having failing liver, if you give your FFP, this PTNR will be automatically corrected. You will not be knowing whether the patient is deteriorating or not. There are other criteria also there. Creatinine is there, some other criteria are there. But the major criteria is INR. So you should not try to give FFP unless until there is a life-threatening bleed. Should not try it. Okay. But we should know that FFP is the treatment of choice when the INR is elevating. Only if there is a bleed or if you are going to transplant the patient, then only you should try FFP. Otherwise, unnecessarily FFP will not be useful. And here it came back to normal within 1 or 2 days. We never gave anything. Okay.
What's the mode of transmission here?
Fecal route is transmission hepatitis A.
And any other differentials for patients coming with fever and motility elevation? May not be in this range, but
We can suspect lepto. Dengue can even be suspected.
there is overlap of dengue hepatitis A also. Co-infections have also been reported. So a lot of patients who initially thought to be having a dengue will have hepatitis A also. So co-infections have also been reported, even from our center itself. I think so.
Vaccination. So what vaccination is available for hepatitis A?
Yes, vaccinations are available.
Vaccination is available for hepatitis A and B.
B.
How do you give vaccination?
1 ml is given, sir.
Duration? 01 is 02, I think. 02 is for hepatitis A. 016 is
Hepatitis B.
hepatitis B. Okay. Suppose you get a hepatitis patient here, you get a needle prick. What do you do? You get a patient who is having hepatitis B, not A, B, and you are getting a needle prick injury from that patient. What do you do? You are already immunized. You are already taken 3 doses. Most of the doctors are immunized. 3 doses you have taken maybe 5 years back. What do you do
We will
immediately?
check the HbSAg titer.
Anti-HBs,
HBsAg
anti-HBs antibody titer. The value is more than 10, then no need to give any more vaccination. If it is less than 10, then you have to take a booster dose. Okay. So you are not immune. Suppose you are not at all immune, what do you do? You have not taken any vaccination for hepatitis B. What do you do?
You need to take antivirals as well as vaccine.
For that, acutely, what do you do? So you get a needle prick injury. That time you remembered that you have taken only 2 doses of hepatitis B. What do you do? You are not at all immune. What do you do?
Immunoglobulin.
Huh?
Immunoglobulin.
Immunoglobulin. There immunoglobulin has got a role. So that time you have to give, you have to take it. So healthcare professional exposure is very, very common in hepatitis B. Hepatitis A, what should be done from our side to prevent infection? Hepatitis A. You are treating doctor.
Ask the patient to have a specific patient should be cared by single staff, and staff should be using
Gloves. Gloves is very important. You have to, whenever you touch the patient, you have to use the gloves. It will not spread through the skin, but the patient may go to toilet and come back. He may touch everywhere. So that can spread through fecal-oral route. So you have to be very careful when you are handling hepatitis A. Once you get hepatitis A, is it lifelong protection or you get a hepatitis A? Are you lifelong protected?
No.
You are protected. That is also one advantage. Most of us are either developed disease or we are immunized by this time. So you will not develop. But if you are not immunized or you are not developed hepatitis A, you have to be very careful. Okay.
Okay.
Okay. Thank you.